Hello, everyone. Thank you very much. And welcome to this last PSM webinar of this year, last ESO webinar, which is called Best of PSOGI. I think you obviously know what PSOGI refers to the last World Congress of Peritoneal Surface Malignancy, which was held at the end of October in Barcelona. I hope many of you who are connected to today's webinar have attended the Congress, but of course, for those who have missed it, hopefully we can give you a little bit of a taste of this experience. I would like to start by introducing the panel for today's experts. I think these will be, for most of you, very familiar names, but we try to really give a mixed impressions about
from various points of view regarding a variety of perspective of countries, of ages, of stages in development, if you will, participation in the PSM world, and hopefully this will really give you a full view of what this version of this edition of the Congress was all about. So let's start by introducing our panel. Aditi Bhatt from India will join us tonight. Ignas de Hing from the Netherlands. A very special presence is Sandra Lara from the Asociación Peritoneal, one of the patient organizations that participated in creating the patient manifesto. We'll talk about it tonight. I think this was a very unique and very important moment of this year's Congress. Then we have Max Lahai from also Netherlands, a radiologist who was part of the organizing committee and really one of the members that most brought us multidisciplinary view during this Congress. Arthur Reis from Brazil, who I think tonight will represent ESPSO, the students, and really all the young participants in this Congress, people who are still in training or just recently finished training. He is a former ESPSO student and certainly is not a trainee anymore, but I think he can bring us the voice of the trainees. And last but not least, Olivia Sgarbura, who comes from Montpellier, from France. And I think will give us a little bit of a view of participation and collaboration that we try to foster with other societies, ISSPP, but not only, that I think also gave us a special touch to this Congress. I would like to show you just a couple of additional slides. Of course, thanks to ESO for allowing us to have this webinar tonight. For all of you who are not members of ESO, I would really like to invite you to join. And I would also like to give a special thank and recognition to SEOC, the Spanish Society of Surgical Oncology, who was the formal organizer along with PSOGI of the Congress and really gave a lot of support. And of course, to the two Congress presidents that made the Congress possible, Fernando Pereira and Pere Brecha from Spain, from SEOC. I think they really deserve to be recognized for their work and the success, as well as the technical secretary of the Congress called Grupo Aran. So hopefully we all agree that they all collectively did a great job and that we have a lot to talk about during tonight's Congress. And then don't forget that ESO supports many educational activities related to PSM. So please check out the ESO website for some upcoming events, which will happen in 2026. The management of HIPEC after CRS course. There is the video course with the participation of Dr. Sugarbaker as well. And then don't forget, speaking of Spain, that the next edition of the ESO Congress will be held in Madrid, in Spain. So put all of these activities in your calendars for the upcoming year. And let's start hearing from our panelists. And the first one will be Arthur.
Hi, Lana. Thank you for the kind presentation. I feel myself a student, and I'm not anymore an ESPSO student, but I feel like one. And as a surgeon, I am very, very grateful for your presentation and also to be here. So, some students of the ESPSO, that is the European School of Peritoneal Surface Oncology, that is a joint venture between ESO and PSOGI. I was one of the lucky certificates in some years ago, and I received the invitation with some friends to pay attention and extract 10 take-home messages. And this presentation was presented on the last session of the Congress. These are my friends, Diego Zambrano from Ecuador, Marina Bosch from Spain, Barcelona, and Nicolo Olivier from Italy, Bergamo. We collected and selected some take-home messages that I will show. And but myself, there are some sessions that were really special, and my highlights were the clinical trial sessions, special for the Cairo 6 presentation, the prehab presentation that was awesome, and the CAR T cell keynote. Obvious, all the artificial intelligence and the innovative presentations were also really nice. And we selected these 10 take-home messages that I will not tell about or speak about each one, but these were the main messages that we had the opportunity to study in this Congress, that was from pathology for the patient's manifesto, AI, MRI, radiology, and also CAR T cells and some translational messages. So we are going to present now some friends of my testimonials that what they thought about the PSOGI and which were the highlights from them.
Hello, my dear PSM community. My name is Diego Zambrano. Greetings from the National Institute of Cancer in Ecuador. I had the honor to participate in PSOGI 2025 in Barcelona, Spain. For the Congress, I want to highlight the most expected clinical trials session with results that I think will impact our clinical practice, as well as the basic and translational research session with discussion of CAR T cells in PSM and the application of artificial intelligence in diagnosis. I really enjoy all the multidisciplinary environments in the sessions of the Congress. And with great
Hi everyone, my name is Marina Bosch and I'm a former student of the SPSO program. The sessions that I enjoyed the most about this last SOGI meeting held here in Barcelona are the ones that were centered mostly in clinical trials, both the ongoing ones, but also on the next session that was held in the parallel room on the young surgeons, the speech given by Mr. or Dr. Turaga, but also the PGO clinical trial. I think it was brilliant. Afterwards, the patient manifesto, I think it was a really nice and new idea as well that I hope we will be able to keep working on that. And last but not least, the live surgery that was held here in our hospital on the pre-congress course. That was a really nice, really fulfilling for us. Thank you.
Hello, I am Silvia Herrero from Bogota, Colombia, and I am part of the European School of Peritoneal Surface Oncology. I was recently in Barcelona for SOGI 2025. It was a really amazing experience for me. Outstanding speakers, high quality talks, and a strong reminder of the power of our peritoneal surface malignancy community. It also affirmed how valuable the EPSO training has been in my practice, the importance to keep learning, stay connected, and continue building bridges across the continents. So finally, I would like to invite you all to join us next year at Sobileta 2026 in Cartagena, Colombia. It will be an extraordinary opportunity to share knowledge, continue strange international collaborations, and growing together as a peritoneal surface malignancy family. See you soon in Colombia. Bye.
Hello, my name is Rafael Santinfus. I'm the head of Department of Peritoneal Disease, Santa Casa de Misericórdia de Porto Alegre in Brazil. And I would like to share our experience during the last PSOGI meeting in Barcelona. bring to us the opportunity to show our experience in the management of peritoneal disease, especially present 11 posters, and for our proud, we could show one during the pitch trial, our experience using artificial intelligence to evaluate the peritoneal disease. The PSOGI Congress offer one exceptional rich environment for knowledge exchange and direct interaction with experts from around the world. This interaction allowed to us to incorporate new strategies, up-to-date clinical practice, and introduce innovations in the management of peritoneal disease. My sincerely thanks to this community of colleagues, friends, who continue to work collaboratively in the fight against so challenging condition. See you soon.
Okay. And then I would like to invite you for this next year. We have two opportunities to come to Latin America. The first one will be in São Paulo in May 7 to 9 of 2026. It's a ESSPP Congress. And in the second semester, we also will have this Latin American PSOGI Congress that will be in Bogota, Colombia in August. Thank you very much.
Thank you very much, Arthur. I think this was a great introduction. Really, mostly very young people telling us their impression, one, participating in the Congress, which is, I think, crucial for us to have a future for this discipline. And I think, for me, the common themes that many of them spoke about was clinical trials. It looks like the more important presence of clinical trials completed and ongoing was something that made an impact, especially on the younger participants. So that's crucial. And then collaboration, exchange of ideas, exchange of point of view. So this, I think, it's a great segue to invite Olivia to speak next. Why? Because I think she will tell us a little bit about clinical trials and their moment in this Congress. And then I do want to highlight that we had several sessions that were really created in collaboration with other societies in this Congress. The European Society of Coloproctology had a joint session during the PSOGI. The ESGO, the European Society of Gynecologic Oncology. This is something new, and I think really important for the PSM world to be open to interacting with other societies, and also bringing to these other societies, I think, our experience and our knowledge and many things that we can contribute. And of course, there were several sessions that were done with ISPP, and Olivia, I think, will tell us more about that. Olivia.
Yes, thank you very much, Lana. Indeed, these are the words I heard also, the keywords I heard also in Arthur's presentation. I heard multidisciplinarity, I heard clinical trials, and I heard patients, I think, from almost all the feedback. So I'm really honored that we chose to discuss about this collaboration, because indeed, as Lana said, they were very spectacular combined session with ESCP, with ESGO. But let's discuss a little bit what happened related to the PSOGI and ISSPP collaboration in Barcelona, and how we're going to develop that, hopefully. So just to put it a little bit in the context, of course, PSOGI is a very, very well-known and historically well-implemented society, based on its focus on peritoneal surface malignancies, and ISSPP is a little bit more recent, since 2018, since you can see. So both societies are focused on the same condition, which is peritoneal surface malignancies, based on several techniques. PSOGI discussed a lot about HIPEC historically. ISSPP discussed a little bit more about PIPEC historically. They both organized several congresses and events. They have sometimes different angles a little bit more technical on one side, a little bit more multidisciplinary on the other side. And they had one joint congress and one initiative. And the fact of joining their forces, I think this really allows us to have like a very, very, very full landscape on the PSM. But let me start by presenting you very, very quickly this joint PSOGI ISSPP initiative, which is PERMIT. PERMIT is the International Clinical Trials Task Force of both societies, an initiative that aims to foster collaborations in clinical trials in the field of peritoneal surface malignancy oncology. In order to do that, we assembled a very, very large panel of, I think, 31 experts, and almost all the people, I think all the people that are here tonight are part of the PERMIT initiative. Our objectives are promoting the creation of international trials in the field, identifying key stakeholders, prioritizing research questions, and disseminating knowledge about funding, reviewing and advising on clinical trials design. So I basically take this opportunity of speaking about ISSPP and PSOGI collaboration in order to invite anybody from the audience that would be in the process of creating a clinical trials to reach us in order to develop this even further at an international level. So I'm really very honored to be part of the pilot team for this joint initiative, together with Ignace de Hing, that he was here with us tonight, and also with Faiz Mohamed. And we really look forward to hear from you reaching us farther. At the PERMIT session, we were also very happy to be able to present with 10 clinical trials, very, very short presentation from each one of them, in 4 different pathologies, in colon, in gastric, in ovarian, and in appendix. And furthermore, what was a really great surprise was to see that all these trials come from different parts of the world, many from Europe, but also many from India, from United States, from Singapore. So basically almost every continent was represented. I really hope that these clinical trials will indeed shape the future of our community, and that we will be able to be more and more present also in the clinical guidelines for each of these pathologies. Beside the PERMIT session, we had 2 more sessions. The first session was dedicated to the management of the young and of the elderly. How do they differ? And this is very representative because both sessions, like I said, were focused on some of the keywords I had previously. Basically, this session was about tailoring the management of the disease to the patient, to the specific patient. And we discussed how pushing the limits for younger and elder patients in peritoneal surface malignancies may have different meanings. It might mean more ambitious resections for the younger patients, but also it might mean better preparation for the elder patients. We also discussed in this session about how it's important to have a holistic approach. And it was interesting to see that keywords that are quite fashionable today, such as longevity and aging, appeared in the presentations. At the end of the session, we also discussed the tailoring of the management of the disease to the clinical status of the patient. So it's not only about age, it's also about the clinical status. And this is how our modern perspectives can reach our more classical and more ancient perspective about medicine. In the second session, we also had the patient in the center, but we also were very happy to be in the middle of multidisciplinarity. And we discussed prehabilitation in high complexity oncological surgery, best practices and future perspectives, going in depth to the preoperative evaluation, to the ERAS guidelines, but mostly in the concept of prehabilitation with its 3 pillars: the nutrition, physical, psychology, but also with the facultative pillars that are oncogeriatrics, addictology, fertility. And it was really nice to see how the discussion went very much in depth into the physical and nutritional and also psychological preparation. And I think patients and doctors, we were very ready to prehabilitate ourselves before surgery. So what's next? We will have in the upcoming years, as you can see, as you could already see, a lot of invitation. We have, of course, our different ESO meetings, but next year, as you could already see, we have an ISSPB meeting, and I'm sure Aditi will discuss the next PSOGI Congress. We would like to develop the permit initiative with an open door to the larger audience. That's why I invited you to reach out, but also to other regions. And I'm sure there will be a permit session at the ISSPP Congress in Latin America. We want to keep on fostering multidisciplinarity and to keep on focusing on the patient. And that's why I would like to invite you also to this Congress, as Arthur already did. Thank you very much. We don't hear you, Lana. I think your micro is off. Dear Lana, your microphone is off.
Sorry about that. Thank you so much, Olivia. Well, I would say inspiring, especially the session on permit, and congratulations on the initiative. I think we can all applaud it, and can't wait to see the impact of the studies that will come out of this initiative. And I think it's already having an impact, as you could hear from the comments of some of the participants. But I think we all know that the road from an idea or even a proposed study or a started study to actual results is sometimes really long one, and we don't always get there. So whenever we have a completed clinical trial with impact, we are just in awe. And one person who has shown us how to do it, and I'm sure we'll do it over and over again, we have the honor to have tonight, and that is Ignas de Hing, who told us during the Congress, and I think will tell us tonight, the results and the impact of a really fascinating study that they did, which is the Cairo 6 trial, that I think we will continue to discuss much more. But for those that perhaps are just hearing about it, I think it's really, really important that we discuss it tonight too. So Ignas, I would like to invite you to show us your presentation.
Well, thank you very much, Lana, for the introduction. And well, I'm very happy to share with you the results of the Cairo 6 trial, and I will try to condense 11 years of research into 6 or 7 minutes. Well, let me first tell you, of course, why this is relevant, and it is relevant because colorectal peritoneal metastases are present in 10% of our patients, so we really need to take care of those patients. Again, they are also present in 24% of patients with metastatic colorectal cancer, so a very relevant topic, I would say. How this is all started? Well, it started, for me at least, with this publication in the Journal of Clinical Oncology, 2003, which published a randomized trial comparing a new technique, cytoreductive surgery at that time, together with mitomycin C, and randomized that against systemic treatment. The results of this trial were positive, and the overall survival of 22.4 months with CRS and HIPEC at that time was really a big achievement. But ever since, cytoreductive surgery and HIPEC has been the gold standard, at least in the Netherlands, for those patients presenting with resectable colorectal peritoneal metastasis. However, quickly thereafter, a lot of French studies actually were published. This one also is very famous, I think, PRODI-7, and they showed better survival as compared to our Dutch practice. Here you see the survival of the PRODI-7 trial, 41 months. But also other French studies showed survival of even 60 months or more. And that made us think why our results, 22.4 months, were so much less than those published in France. And we compared all those protocols of our study in the JCO with the studies in France. And one big difference was the fact that we gave cytoreductive surgery and HIPEC as a standalone procedure in these patients, whereas in France, all these patients received neoadjuvant systemic therapy and adjuvant systemic therapy. So that made us wonder what would be the value of perioperative systemic therapy. And a systematic review that we performed at the time showed there were no prospective data available that could answer that question, and that's why we performed the phase 3 multicenter superiority trial with the name CAIRO-6. Our hypothesis would be that the addition of perioperative systemic therapy to CRS and HIPEC would result in a 3-year survival of 65% as compared to 50% with CRS and HIPEC alone. So we also thought that this French schedule of giving perioperative systemic therapy would result in a better survival. Patients could be included when they had pathologically proven peritoneal metastasis with a PCI less than 20, no systemic metastasis, no systemic treatment 6 months prior to enrollment, and patients should have a good performance status. The overall survival of our study, the primary outcome of our study was overall survival, and to answer this hypothesis, we needed 358 patients to be included. We performed a nationwide trial, meaning that all 9 Dutch HIPEC centers and 1 center from Belgium could participate, and the systemic treatment was very much protocolized, so we would have comparable groups within each center. The HIPEC regimen was mitomycin C, 35 milligrams per square meter, and oxaliplatin was no longer part of the trial after the PROGES 7 trial was presented. The follow-up was standardized, including 6 monthly CT scans and CAA measurements. And this was the design of the study. Patients were randomized 1-to-1 to either receive CRS and HIPEC alone, as was the Dutch standard, versus perioperative systemic therapy consisting of 3 to 4 weeks systemic therapy with bevacizumab, followed by 1 to 2 cycles of systemic therapy without bevacizumab, then CRS and HIPEC, and then adjuvant treatment. This was how patients were actually randomized. 178 patients were randomized to CRS and HIPEC, and of these patients, 154 patients received CRS and HIPEC. In your perioperative systemic therapy group, in total, 138 patients eventually underwent successful CRS and HIPEC, and adjuvant systemic treatment was given to 71 patients. Patients were well balanced between both treatment arms, so no problems in here, very comparable, all these patients. And I will go straight to the primary endpoint, which was overall survival in the modified intention to treat group. And this showed that the overall survival of those patients receiving perioperative systemic therapy was 44 months as compared to 39 months with surgery alone, resulting in a hazard ratio for death of 0.85, which was not statistically significant difference. Interestingly, the 3-year survival was 54 versus 53%, so no major differences in here, and the study was actually powered to detect a 15% difference at this time point. Overall survival after CRS and HIPEC was better, as it was a selected group of patients, and was 54 months in perioperative systemic therapy versus 35 months in surgery alone, and again, no statistically significant difference in here. A key secondary endpoint was time from randomization to progression or death, the progression-free survival, and here there was a significant difference in favor of those patients receiving perioperative therapy, and interestingly, after 5 years, there's a still 14% difference in both treatment arms, but at this time point, the groups are very small, so we need longer follow-up to that. Postoperative morbidity and mortality, interestingly, a little bit more complications in the group treated with perioperative systemic therapy, however not significant, probably due to a higher number of anastomotic leakages, maybe due to bevacizumab, but fortunately mortality was low in both groups. To show you the major systemic therapy-related toxicity, also here quite some complications with systemic therapy and resulting also in 1% mortality. Then I go straight to subgroup analysis, and I'll skip this in terms of time. But what we did see that there was a treatment effect in right-sided colon cancer as opposed to left-sided colon cancer. And this was seen not in metachronous right-sided cancer, but in synchronous cancer only. It was a significant difference, 22 months versus 45 months. It was highly significant and a relatively large subgroup. So although this was not, the study was not powered for this question, I do think this is important information. So to conclude, what is the value of perioperative systemic therapy? Well, the addition of systemic therapy to the surgical treatment for colorectal peritoneal metastasis prolongs progression-free and disease-free survival. However, it does not prolong overall survival in the entire trial population. It may prolong overall survival in those patients with right-sided tumors and synchronous peritoneal metastasis. A lot more to tell, but with a look on the clock, I will leave it here, and I'll give the word back to Lana.
Thank you so much, Ignace. I think this really deserves so much discussion, and I'm sure we'll have a little bit of time at the end to ask you some questions and pick your brain. I think the study is fascinating from so many aspects, and one of them is really how to interpret this correctly. And I would say that we as surgeons, the experts in PSM, really have the almost obligation to talk about these trials and help explain them, the Prodigy one and this one, to our colleagues that perhaps are less familiar with really the details of these studies and how to interpret them. I feel that it's easy to misinterpret, including the Prodigy 7 trial was misinterpreted frequently. So perhaps we'll have some chance to talk about it a little more, because ultimately, of course, we really want to do what's right for the patient, to choose the right treatments at the right time, sequence them the right way, et cetera, et cetera. So this brings me really to the patient as the center. And I am so proud that we did have a chance to have a very special session, but not only a session, but really produce a document that I think will have a lasting impact in the world of PSM, and that is the patient manifesto. I would like to invite now Sandra Lara to tell us a little bit about this experience, about how she and other representative of patient organizations feel about the patient manifesto and what they expect really to see as impact of this document. Thank you so much, Sandra, for being here with us.
Hello, thank you very much, Lana, and thank you to all the organization for inviting me to this session, and also for including the patient manifesto as one of the highlights of this PSOGI Congress in Barcelona. I have to say that it was challenging to kind of put in black and white the needs and challenges of patients, but okay, sorry. I think the presentation is not working. I'm gonna try it again. Sorry about that. Sorry, guys.
We could see your screen.
It's just the presentation is not moving forward. That's the problem, basically.
You can just stop the slideshow and run the slides. You can just scroll. I think that should work.
Okay. Let's see now. Okay. All right. Sorry about that. So the first thing and why we built this manifesto was for a very simple reason, is that we realized that patients from very different countries were coming across with the same needs and the same challenges, even considering different types of healthcare, different countries, different diagnosis subtypes. We were having we were coming across the same type of needs. So the experiences were similar. We were facing delays in diagnosis and treatment, and we were experiencing an unequal access to expert and multidisciplinary centers and treatment. So we started working 1 year prior to the Congress, actually, and we created this coalition of 7 different organizations of 5 different countries from UK, US, France, Netherlands, Spain. And we started working together to identify those needs. And from the very beginning, we wanted the manifesto to be an invitation to work together and to collaborate among the different patients organizations, but also with the health experts and professionals. And from the very beginning, we were very clear that we wanted the manifesto to be a practical tool, not just a document, something that could go beyond the Congress and help create a real impact on the lives of patients and their families, not just something really abstract or purely theoretical that to put in a document and ends there. We wanted to be something that could have a real impact in the lives of those affected by peritoneal malignancies. So the main focus areas and the pillars of the manifesto are not really a surprise. There are 6 main areas of focus, and we think that they reflect very well-known issues, but we still felt necessary to address them because we felt that they were not they were not addressed in an optimal way. So the first pillar of the manifesto will be global awareness and education. You probably are already aware of that. From the patient point of view, the first time we even listen or heard or know about the peritoneum is when we are diagnosed. I mean, mostly normal patients don't even know what the peritoneum is. And so that will be the first challenge. Even when we try to organize campaigns or awareness journeys to communicate with the general public, the first wall to cross will be actually to talk what the peritoneum is, because there's no point to talk about peritoneal malignancies if you don't even know what the peritoneum is. So global awareness and education, make those diseases visible. Of course, early and accurate diagnosis. We find many patients that they get their diagnosis very late. Many times they are misdiagnosed with some other types of disease, especially on those types of malignancies that are more rare, like pseudomyxoma, peritoneal, and mesothelioma. The access to expert care and into multidisciplinary teams probably is one of the biggest challenges, because many patients have to go through a very difficult time and deal with a lot of bureaucracy before they are really addressed to an expert center or to an expert team, and that makes to lose more time and to lose opportunities to get a proper treatment. Also, the equity access into the clinical trials. You have already been discussing about clinical trials and the involvement of patients in these clinical trials, and of course, research and innovations. We think that to listen the voices of patients can make a difference really into make sure that that those researchers and those trials are focused on the real needs of the patients. And the last one, but not the least important, is the psychosocial support and quality of life. I heard Olivia talking about rehabilitation and considering some things as fertility, for instance. We see every day fertility or surgical menopause. We see patients that are very young, really young. I remember when I was diagnosed with pseudomyxoma and I started to look out for information, and I remember the average age was 55 or 60 years old, and I was on my 30s. So we believe that not only the treatment has to be considered when you are communicating with the patients, but also the life planning of the patients. What are the expectations of those patients, and maybe bring some conversations about what quality of life can be for different people. It's not the same for a 33-year-old than a 65-year-old. So I think that has changed as well the dynamics of the communications among the professionals and the patients, and also the psychological aspect has to be addressed. We wish that in every, after every consultation, there will be an oncological psychologist to be there and to support the patients. But that's one of the challenges. But even if it's the last, pillar of the manifesto, the support and the quality of life probably has to be in the center when in the communication with the patients and professionals. And just to finish, by aligning, scientific progress and communicating with patients, and to go, beyond the data and considering, the patient as someone, not only numbers, not only statistics, someone that has a life, have plans for the future, I think is the way that we can improve the lives of all those affected by these diseases. So those are the organizations involved in the manifesto. I have to say that we are growing. There are more organizations from other countries getting involved as well in this coalition. So probably for the next PSOGI Congress, we can come back and review all the patient manifesto and see how we have improved in those 2 years, and to listen as well from more patients' voices that I think is really important. Thank you very much.
Well, I can only say thank you, Lara, not just for your Sandra, not just for this participation, but really for spearheading this initiative. I think this last sentence that you showed us really summarizes what we have to remember every day. And one thing that gives me a little bit of happiness is that when I look at these points that are the pillars of the manifesto, I think we think about the same things, and hopefully even through the sessions and the program of this Congress, we try to address them. And there certainly is a long way to go, but I think we are sharing these points 100%. So thank you for making it so clear, and hopefully this will help overcome these barriers that still you patients face every day and in every country. One of the words that you talked about was multidisciplinarity. And we completely agree with you on that. And hopefully we made it clear by making this program of the SOGI quite multidisciplinary. So I would like to invite Max first, tell him thank you for being such a powerful voice in the program of the Congress and in the PSM world in general. So tell us a little bit about what's new in the world of radiology and PSM, because I think there was quite a bit of new, and actually was one of the points that was really highlighted in the take-home messages. Max.
Yes, thank you for your kind introduction. And yes, I can certainly attest that if you're a surgeon and you're going to the PSOGI, please bring your radiologist. I think he will enjoy the Congress also. So, but further ado, I would really like to talk about the DISCO study, as a study what we performed in the Netherlands together with a center in Shanghai. And as you already mentioned, was mentioned by Inyas, colorectal peritoneal metastasis occur in around 10% of the patients, and we know that cytoreductive surgery offers survival benefit. However, we have quite a number of open-close surgeries, and that's one of the points is that we as radiologists really struggle in depicting peritoneal metastasis, and especially when you talk about PCI, well, it's really hard on CT. CT underestimates between, let's say, 12 to 80% of the PCI. So that gives you only a vague idea of what's happening in the abdomen. We know that MRI offers superior detection, but we really didn't know what would be the impact of better imaging. So the objective of our study was, can diffusion-weighted MRI reduce the futile surgeries compared to standard surgery? And we did it with an international multi-center randomized trial with 7 Dutch centers and then also the Fudan University Shanghai Cancer Center. We analyzed 243 patients, and patients were randomized between MRI, and we have a control group. In the MRI, in the control group, people could do, the surgeons of the multidisciplinary team could perform any diagnostic workup they wanted and perform every surgeon what they normally would do. However, in the MRI arm, patients received an MRI, and based on the PCI, what we saw on MRI, we had 3 groups. Patients with very limited PCI, so below 15, they could go straight to surgery. If the MRI PCI was above 24, well, then we thought it would be probably a palliative care, and these patients were biopsied just to make sure that we really saw tumor there on the MRI. And then the middle group, the borderline group, well, these patients got an additional diagnostic laparoscopy after the MRI. And the primary endpoint was to see what the number of futile surgery would be in both groups. And we defined futile surgeries as staging procedures in limited or inoperable disease, open-close procedures, incomplete resections, and patients with no peritoneal metastasis and there was a surgery performed. So these were the results if you took all the cohorts together, and you would see that in the MRI group, there's a clear reduction of futile surgeries. If you look by cohort, then you can see that the difference between the two groups is very big in the Dutch cohort, where we saw a big reduction from almost 60% to 22% of futile surgeries. On the other hand, in Shanghai, they performed more laparoscopies with the use of this MRI algorithm. And that's due to the fact that they use other PCI thresholds to operate on, and they also always start with a laparoscopy to see whether they can laparoscopically remove all the tumor. So that's a teaching point. The impact of MRI really depends on your laparoscopy policy and which thresholds you're going to use. If you look at the data, you can really see that from the control group, there were 71% staging laparoscopies versus 15 in the MRI group. So it's a big reduction. If you further zoom in on the surgical procedures, almost a quarter of the patients in the MRI group didn't had any surgery at all. I think that's really important also from a patient perspective, because you don't want to operate on patients who, well, don't need a surgical procedure. And we saw also a more complete resections and above all, less open-close procedures. So the key insights of the DISCO trial were that MRI really results in fewer futile surgeries, so especially staging laparoscopies and open-close procedures. We think it supports the integration of MRI in the preoperative staging in healthcare settings like the Netherlands, which we also now received a grant from the Dutch government to further implement the MRI in the Dutch healthcare. And the impact of MRI depends on the laparoscopy policy and the PCA thresholds. And this, I would like to finish my talk with this. And if there are any questions, please let me know.
Thank you so very much. And I couldn't agree with you more. I think radiologists are really our best friends in terms of PSM surgery. And I do hope that we will have a lot of radiologists on the next edition of PSOGI. And this will really be our last last presentation for today. From Aditi Bhatt, who hopefully will give us her impressions, what was good and what was bad about PSOGI Barcelona, but mostly will give us a taste of what we can expect about from the next edition of PSOGI, which will be held in India in 2027. Aditi.
Okay, so thanks a lot, Lana, for the invitation. And there is already a lot of pressure on us, though our meeting is 2 years away, because for the first time, the PSOGI meeting will be outside of Europe and North America. A meeting was planned in China in 2020, but it became an online meeting due to COVID. And so this is my take on what was very good about the Barcelona meeting. I had the opportunity to watch the program evolve because I was part of the PSOGI board and I handled the PSOGI social media. And what I felt was that the organization was seamless. There was a large group of surgeons from Spain, but they took it a step ahead. The organizing team was truly multidisciplinary and multi-country, and there was a personal touch in all the communications. The speakers were involved in planning of the sessions, which was very new and very good, I would say. The feedback that I got from a lot of participants was that the website was very easy to navigate. The team was very communicative. And most importantly, for the very first time, we had special packages for low-income countries. And I think this is something that should continue. We should not just look at the low and high-income countries, but also the distance that people have to travel. It has to be a viable option for people to attend the meeting. And a special thanks to Anna Lemon and Patricia Laurent, who sent me this beautiful picture. They were behind all the organization. Starting the Congress with a workshop was a brilliant idea. Many Congresses do it. And I think the participation, the course was full. The capacity was 100. There were 94 participants. We saw a brilliant surgery by Lana and Domenico. It was a difficult case. We saw the treatment decisions change. There were a lot of discussion, and all I can say is that is something we would very much like to emulate in our Congress. The other thing that I liked about this meeting was that there was a lot of focus on the basics. Whereas clinical trials, translational research, artificial intelligence, everything is important. But at the end of it, we are surgeons, so we is still a surgical society. And we have to talk about recent advances in surgical procedures. It cannot be presented as evidence, but sessions such as these on advanced surgical techniques are really practical and useful. Then there were sessions on the plasma peritoneal barrier, oncological hypothermia, and also the rationale for intraperitoneal and systemic treatment. Those who missed the SOGI meeting, the recording is available online. If you are a registered participant, you can watch the recording. And even if you attended the meeting, you would have missed a lot of sessions. So it's good that the recording is available, and I'm going to watch a lot of sessions that I've missed. Of course, this has been brought out before. Having a session for young surgeons, having a mini contest was a brilliant idea. I think they had 45 submissions. And Ana Carolina from Brazil, I think she was the happiest person if you've seen the pictures on social media. So this is something we would very much like to emulate. Then we saw a return of the Meet the Professor sessions. In the last two congresses, we were missing those. The good thing is, if you were a speaker, you could just walk into the session, and I really enjoyed the sessions that I attended. For me, this was the most iconic slide. I think one message that was underlined above all in the meeting was that MRI increases the diagnostic accuracy of imaging. The patient manifesto, of course, we've already heard a lot about it, and it is going to be carried forward. You will hear a totally different perspective in India because socio-culturally, our country and our region is very different. We will also look at sessions on quality of life and palliative treatments. The other thing about the meeting was the large number of abstracts, the posters, and all these posters are available on the website and in the application. And I'm going through the posters now. So far, I've finished 4 out of 7 sets, and these are my 2 picks. Very interesting work in the posters, so do go through them. Lastly, these were all the routine sessions, and one message that I would like to highlight is that the SOGI has many consensuses that have been published, and most of these results are published as open access manuscripts, so please go through them, please follow the recommendations. You will find them soon on the SOGI website. So do have a look at our website. Ignas D. Hing is the webmaster for the SOGI, and the website is being updated. Lastly, we announced SOGI 2027, and this is Somashekar, my colleague, who has many ideas. And one of his ideas was to give a heavy discount on registrations for 10 days. And in those 10 days, we've got 213 people registered for SOGI 2027. So moving forward, we are going to open another discounted registration rate. So if you're interested, please avail of this opportunity. For us, we have very large shoes to fill to match the organization of SOGI 2025. We are going from Barcelona to an Indian city that many of you have not heard about. But we are going to do our best to keep up to the high standards of SOGI Barcelona. Thank you.
Thank you very much. I have zero doubts that this will be just an outstanding Congress in content, in fun, in people. So I think we will all learn a lot, and I'm very much looking forward to it. I think all of you really respected the time, so I assume that I'm the one who spoke too much because I see that it's 7, so we don't have much time for discussion. But I wanted to invite all of you who gave these nice presentations, if you did have some last thought, some message that you wanted to share, I think we can extend for a couple of minutes more and hear from you before we close.
Shall we start? So I will start. From my side, from representing the young surgeons and also the ESPSO students, in the chat, some young surgeon, general surgeon, asked about ESPSO or if he could visit or somehow do an observership or fellowship. The European School of Peritoneal Surface Oncology is training, certification, and well recognized and established way to become an expert in peritoneal surface oncology. We had more than 80 participants here, and probably most of them are young surgeons interested in this high complexity disease and also procedures. So in the ESSO website, the European Society of Surgical Oncology, we have all the folders and all the information regarding ESPSO. I recommend this training changed completely my life, and also all this network and all this community is well established between ESPSO students. We feel very, very, how can I say, very accepted and well received in this community. So this is my final talk and speak for you. Thank you very much for the invitation.
Thank you, and nice words to finish. I'm not sure if anyone else wanted to make a comment. I just wanted to share two really quick information. There will be a special issue of the EJSO published related to the Congress, where we will try to gather a collection of articles. It will include the patient manifesto as well, that really summarize the key messages from the Congress. So look out for that. That will probably be published somewhere in the middle of 2026. And then the second message is that was mentioned from on Aditi's part. The Congress was recorded, and these recordings are completely available through the website. For those who are registered for the Congress, they are free, and for those who are not registered, they only involve a payment of, I believe, 50 euros, which I think is really a very, very acceptable expense to get access to all of this content, which, as you heard, was of great quality and I think really impactful. So I think our time is up. I would really like to thank all of you who participated, the panelists, the participants, ESSO, and of course the Congress organizers for giving us a great PSOGI, and hopefully this webinar was also pleasant for you. I apologize for my surroundings. I had a little bit of a traffic problem and had to do this from the car, but hopefully the quality of the audio was good.
Sorry, Lana, can we have just one more minute?
Of course.
Yeah, sorry. I forgot to tell you before, but we have decided to have, we were missing a day to bring awareness for peritoneal malignancies. So we have decided to establish the 30th of October, which was the day that we presented the manifesto at the PSOGI Congress, as the World Peritoneal Malignancies Day. So just to
congratulations.
Like this, that's very new.
It is very new. Thank you for sharing this.
It is very new, but after the Congress, we got a meeting and we felt that it was important to have a day that could help to bring awareness to these malignancies that are very not very well known for the public. Thank you.
Congratulations for the initiative. I think it's great and we will all support it. For me, it's going to be very, very easy to remember the date because it's my birthday.
Oh.
Well, thank you very much. Thank you, all of you. And looking forward to the next webinars in 2026. Bye-bye.
Bye-bye. Thank you so much.
Thank you, everyone.